Yeah, all right. Let's discuss cirrhosis today. Now, before we go into the pathology of the liver, I think we should discuss how the liver actually looks like. So we need to visualize this as one of the a lobule of the liver, which has a central vein, of course, in the center, and has a portal triad at the 6 corners of this hexagon. And now you can see from here that you have this portal triad, which comprises of a portal vein, it has a bile duct, and it has an hepatic arteriole. You have an A, and this is a portal vein. The movement of the blood, if you can see, is from the portal triad towards the central vein. So as far as anatomy, physiology, or pathology is concerned, we have to understand this concept that the movement of the blood is from the portal vein towards the central vein. Now, how this movement of the blood occurs, you have these things called as hepatocytes. You have these hepatocytes which are arranged in the form of these cords, and in between the cords of hepatocytes you have this space which is called as the sinusoid. Now we will try to zoom it out a little. Now if you have this hepatocyte over here and you have a hepatocyte over here, which are actually polygonal cells with central round nucleus, abundant cytoplasm, right? So these cells, when we see them here, they are lined by a thing called as an endothelium, right? They should have an endothelium. So this space where the movement of the blood actually occurs is called as a sinusoid. And this sinusoid is lined by endothelial cells. These are the endothelial cells. And if you look very carefully, there is a space between the hepatocyte and the endothelial cell. And this space is called as space of Dis. Now this space of Dis is important because we will be talking about the vascular malformations in a cirrhotic liver, and this space of Dis is something which is going to accumulate or have a lot of fibrotic tissue, which is going to disrupt the movement of the things from hepatocytes to the blood and vice versa. Now what happens over here is whatever transport is happening over this area. That means all the detoxification, all that metabolism which is being done by the hepatocyte, synthesis of dietary amino acids, carbohydrates, lipids, vitamins, all that serum protein productions, and all the detoxification is occurring along this gradient. So this gradient has to be a very smooth gradient, only then the function of the liver will be happening. So we can see here now the movement of the blood is from the portal triad towards the central vein, and this central vein from this, so we have this portal vein, it goes all the way into the central vein, and from the central vein it goes to the inferior vena cava, and from inferior vena cava it goes to the right heart, right? This is how the flow of the blood is. Now what happens inside this acinus? What happens inside this acinus? We can see here that this part of the acinus, which is the portal triad, is going to have the maximum amount of oxygen, and the part which is away from the portal triad is going to have the minimum amount of oxygen. So based on that, we can divide these acinus into zone 1, zone 2, and zone 3, and we can also call this zone 1 as the periportal zone. We can call it as the mid-zonal area, and this one is the centrilobular area. These are the 3 zones of this acinus. Having said that, we also have to understand that acinus is the functional unit of the liver and not a lobule. So if we have to make a functional unit of the liver, we, instead of drawing this hexagon, we have to draw something like this. You have the central vein, you have this portal triad which is over here, and you again have a central vein over here. So you have this portal triad, you have this central vein on both sides, and this is acinus. This is again an acinus. This is how the movement of the blood is going to be. Instead of making it look like a hexagon, we have to think in these terms, right? So if you have some kind of injury to the liver, let's say the first type of injury is some kind of an ischemic insult, right? Some ischemic insult has happened. So this is ischemic insult. What part of the liver, according to you, will be most affected? Since this part is having the maximum amount of oxygen and this part is having the minimum amount of oxygen, if at all there is ischemia, the centrilobular zone will be affected. Let's see if somebody is having a CVC, because of right heart failure, there is failure of the right heart and there is congestion within the central vein. There is no movement of the blood from the portal triad towards the central vein because of right heart failure, and the patient is suffering from chronic venous congestion. So the type of necrosis or the type of area which is going to be affected is going to be the zone 3. That means this is the area which is going to be affected, right? This is the area which is the zone 3 or the centrilobular area. So it's called a centrilobular necrosis. If there is a second type of insult, for example, some kind of a toxin, including various drugs, alcohol, if that kind of drug, microbial, all those infectious agents, these kind of insults are going to be maximum in this area, because this is the area which is going to be having the maximum amount, and this part of the liver is going to be having the minimum amount of those toxins. So if at all somebody is having a toxin or a microbial insult, this zone is going to be most affected, most often will be affected. That's the periportal zone is going to be affected the most. This is how it looks like. You have this three-dimensional structure. You can see these are those small sinusoids which are lined by the endothelium, and you have a space of this in between. This is the central vein. These are the three things within a portal triad. You need to have a hepatic artery, a portal vein, a bile duct, and if you see very carefully, this part is the only part in the liver which will have some fibrosis, whereas this part and this part is completely devoid of fibrosis. So that means central So this is a three-dimensional structure, and you can see this is the portal triad, which is comprising of a bile duct, and this part is comprising of a portal vein and a hepatic artery. So these are the three structures which are present inside the portal triad. And you have the central vein, and you have to be very careful and you must see that this central vein is completely devoid of fibrosis. This part may have some fibrosis. This part in fact has a lot of fibrosis, a fibrotic tissue around it, whereas this part is completely devoid of fibrous tissue. So from the sinusoids all the way up to the central vein, we do not have any fibrosis. So here you go, you have this central vein, you have this portal triad which is going to have this portal vein over here, you have this hepatic artery, you have this bile duct over here. So this is how it looks like. You can see this is the portal vein, this is the hepatic artery, these are the bile ductules. You can see two or more of these bile ducts, and they are lined by the round cuboidal cells, whereas hepatic artery is a thick walled because it's an artery, so will be slightly thicker than this portal vein, but it's going to be slightly smaller than the portal vein and will be lined by endothelium. So this zone has some fibrosis, and this fibrosis is extremely limited to only this area, that we call it the limiting plate. This is the limiting plate, after which you do not see any fibrosis. And the same happens in the central vein. You don't have any fibrosis in this area as well. So from the sinusoids all the way up to the central vein, there is no fibrous tissue. You can see over here again, you have the central vein and you have these portal triads at all the 6 corners of this central vein. It's more of memorizing, it's more of a visual memory kind of a thing, because sometimes you may not be able to see all the portal triads around the central vein. So if you see a central vein, you have to see in all the directions and look for the portal triads. This is how the portal triads may look like. You have this central vein again, you have this central vein over here, and you have this portal triad over here. This is one of the most beautiful portal veins. This is, what is this? This is a bile duct. This is a bile duct. You can see a bile duct over here, you can see a bile duct over here, and you have this hepatic artery over here, which is lined by endothelium, slightly thicker wall, and you have this thin wall but a large portal vein which is present here. And this area has some fibrotic tissue and some inflammatory cells. And you can see here, this is the part which, after this, you do not have any fibrous tissue. That means this fibrous tissue is limited to only this part, and that's why we call it the limiting plate. This is the central vein, and you can see some RBCs going, they're flowing down into this central vein, and you have all these beautiful hepatocytes which are arranged in the cords. So we have learned that all these hepatic injuries, you have type 1, you have the zone 1, zone 2, and the zone 3. This is the functional unit of the liver, and zone 1 is something which is most commonly affected during toxic injuries, and zone 3 is the one which is more commonly affected in ischemic injuries, and we call it a periportal type of necrosis, and in this case you will have a centrilobular type of necrosis. Now, a few changes which may happen in cases of injury, which may happen in any cell, and the same thing happens in the liver. You will have degeneration, you will have intracellular accumulation in the form of fat, which will get accumulated inside the cells. So these type of changes are called as ballooning degeneration, because the cells are going to swell because of water imbibition, and there will be fat metabolism will be disrupted, and fat is going to accumulate inside the hepatocytes. So in cases of alcoholic liver disease, Ray's syndrome, acute fatty liver of pregnancy, liver of obese, that means if you are fat, your liver is going to be fat, right? So liver of obese or diabetic individuals will have ballooning degeneration and steatosis. Apart from that, you may have some changes pertaining to cell death in the form of necrosis and apoptosis. If it's a centrilobular type of necrosis, it's more likely to be an ischemia. If it's a periportal type of necrosis, it's more likely to be a toxic reaction. There's going to be an interface hepatitis. There's going to be a bridging necrosis. That means a type of necrosis which is bridging from one area towards the other. It may lead to submassive, and then finally to a massive necrosis. And if it is apoptosis, you will see these pink, round, highly eosinophilic bodies, which are called as the Consilman body. These are the Consilman bodies. These are how they look like. This is a microvesicular type of steatosis. Why this thing looks very clean, this looks very empty, because the fat was there. The fat is not present here. It's not that we cannot stain the fat. HNA cannot stain the fat. There's no fat, because during processing, all that fat has been dissolved. So when you take a histopathology section, it has to undergo a lot of processing, and during those solvents you have all these alcohols and stuff which is going to dissolve this fat. So if you need to have a special stain for fat, you need to have fat in there. So if you subject the tissue to a usual histopathological processing, the fat will not be there. So you need to have something called as a frozen section. Frozen sections are required if you want to see the fat, because if you freeze the tissue and then cut it, the fat will be preserved, and then you can use those special stains for fats like oiled red oak, Sudan, black bee, and so on. All these are the special stains for fat. Here you can see this is a microvesicular. That means what happens in microvesicular is you have these, if let's say this is the hepatocytes, you have these small vesicles which are present inside the hepatocytes, and slowly these small vesicles will undergo fusion, and they may lead to a large molecule of fat, a large fat structure, and slowly, even in some cases, you may have something called as a fatty cyst, because when these hepatocytes which are present like this, and you have large fatty molecules, fatty stuff inside these, and they may rupture, and when they rupture they will lead to formation of a big fatty cyst. It's called as a fatty cyst, which is again can be seen in fatty liver. So here you have the macrovesicular type of hepatic steatosis, and you can see the nucleus has been pushed towards one side, because that's what fat is going to do. The fat is going to push the nucleus towards one side. You can see these all these nuclei have been pushed towards one side, and commonly seen in obesity, diabetics, and some toxic injuries. The cells will undergo regeneration, and we know that liver can undergo a lot of regeneration because of presence of these oval cells which are present near the canals of Herring, and which is actually a hepatobiliary stem cell niche in which all these stem cells called as oval cells will be present. And liver can regenerate itself even if you take out almost 60% of the liver. You can remove 60% of the liver, but still it will be able to regenerate itself within 4 to 6 weeks, provided it can survive all those insults. There will be inflammation, fibrosis. Fibrosis is going to be a bridging fibrosis. That means from, let's say, from the portal triad towards the central vein, this is bridging fibrosis. From one portal triad towards another portal triad is bridging fibrosis. From one central vein towards another central vein is a bridging fibrosis. So from central vein to portal vein again, it could be a bridging fibrosis. So if this kind of bridging fibrosis occurs, it will cause a lot of fibrosis, and we have learned that the fibrosis is seen only in this area, and we are not supposed to see fibrosis anywhere else but the portal triads, and may have adductular reaction. Now coming to cirrhosis, this is one of the top 10 causes of death in the Western world. As per definition goes, it's a diffuse process characterized by fibrosis and the conversion of normal liver architecture into structurally abnormal nodules. These are a few words. It's diffuse, it's because of a lot of fibrosis, and will have formation of these abnormal nodules. What is the most common cause? The most common cause is alcohol intake, and that type of necrosis or cirrhosis is called as a Lennox cirrhosis, which is also called as a nutritional cirrhosis. Chronic infections by chronic hepatitis B virus, chronic hepatitis C virus, because they both lead to a chronic hepatitis, so they may lead to cirrhosis. Autoimmune hepatitis, biliary diseases, iron overload, iron overload, all these are very rare causes, and around 10% of the causes are unknown, so we call them as cryptogenic cirrhosis. 3 main characteristics. Now you cannot afford to forget these 3 main characteristics of cirrhosis. Number 1, bridging fibrous septae, parenchymal nodules, and disruption or effacement of the hepatic architecture. So you're going to have that bridging fibrosis. That bridging fibrosis, this is bridging fibrosis, which is from one area to another, is going to make a hepatic nodule, and if that nodule is less than 3 millimeter, we call it a micronodular type of cirrhosis. If it's more than 3 millimeter, we call it a macronodular type of cirrhosis. But anyways, that is not important. That's only a structural differentiation. It does not really carry any clinical significance. More or less, they are small nodules, and here you have these big nodules more than 3 centimeters. They may reach up to 1 to 2 centimeters in a few cases, right? So you have this bridging fibrous septa, you have parenchymal nodules, and of course, if you have this thing, you You cannot expect to see that your lovely hexagonal structure of the liver, right? So that hexagonal structure will not be seen, so there will be a complete disruption of the architecture. So you cannot forget these three important characteristics of cirrhosis. Another important feature is it is irreversible. If somebody comes and tells you no problem, your cirrhosis will be fine, no, he is lying. Cirrhosis is completely irreversible. Some amount of fibrosis can be reversible, but once you have this diagnosis, once you have a clinical diagnosis of cirrhosis, then sorry, you will never go back to a normal liver. The only thing which you can do is a liver transplant, or else the liver will not be fine again. This is an end stage of almost all the chronic liver diseases. It is associated with huge degree of nodular regeneration. So some nodules may become autonomous, some mutations may accumulate, they may have their own vascular supply, they may have their own blood supply, they may have formation of new blood vessels within that nodule. So all these things will cause increased risk for primary liver neoplasm or hepatoma, also called as hepatocellular carcinoma. Hepatoma though sounds very benign, but it's not a benign tumor, it's hepatocellular carcinoma. Hepatoma is actually quite misleading, it's a misnomer, but it's actually a carcinoma. Now, coming to the pathogenesis, there are a few changes which are going to be very evident and which are going to cause that extensive amount of fibrosis, extensive amount of nodule formation in a cirrhotic patient. Now, hepatocellular death, that's the first thing which is going to happen. There will be some regeneration, which is going to be a compensatory response. There is going to be excessive amount of fibrosis, and that fibrosis is going to deposit in those areas where you never ever had any fibrous tissue. Along with that, you will have some vascular changes. So these things will keep on going in a loop-like fashion and will cause diffuse process called as cirrhosis. So hepatocellular death is because of toxins and viruses, whatever etiological agents we have seen earlier. There will be some amount of regeneration, which is a compensatory response, and fibrosis. Now this fibrosis is actually a wound healing reaction. We generally have type 1, type 3, type 5, type 11 collagen, which is mainly seen in some of the areas, and they are commonly seen in those areas like the capsule of the liver, the portal triad, and some amount of fibrous tissue is also present near central vein, which is not very evident. So if you have a lot of fibrosis, all these types of collagens which were actually absent in the space of Dis, remember that space of Dis which is between the sinusoidal lining and the hepatocyte. So that space of Dis never had any collagen. They may have a few type 4 collagen, but they don't really have these types of collagen. So these types of collagens will be deposited in the space of Dis and is going to lead to formation of these fibrous bands which will be separating those nodules. So here you go, you have these hepatocytes which have these bile canaliculi. They have nice microvilli over their surface to increase the surface area for absorption. This is the sinusoid where the movement of the blood is occurring. Let's say the movement of the blood is from here. I mean the portal triad is this side and the central vein, let's say, is this side. So there's movement of the blood which is from this side to this side. You have this sinusoid which is being lined by these endothelial cells, and they also have a specialized macrophage for the liver called as a Kupffer cell. Now you have these endothelial cells which have these fenestrations, which have these fenestrated sinusoids. It means which allows the movement of the things from the blood to the hepatocytes and exchange of nutrients and detoxification. All those normal structures, normal functions will be happening along this gradient. You also have these quiescent stellate cells which are involved in the fat and vitamin A metabolism. They are also called as ito cells. They were previously called as ito cells, but now they are called as a stellate cell. Now, when you have liver injury, when you have a liver fibrosis, when it goes towards a cirrhosis, you will see a few changes. The first thing you will see, there is loss of microvilli, right? Can you see that? These microvilli are absent in these hepatocytes. You can see these quiescent stellate cells or ito cells have become activated, and they lead to formation of a myofibroblast. Plus there is accumulation of dense extracellular matrix. Why this happens? These cells are having injury, the sinusoids are having injury, epithelial cells are having injury. All these cells which are causing injury are going to produce a lot of cytokines, and these cytokines are going to activate transforming growth factor beta. This is going to activate a number of collagens, the fibrous tissue, which is going to deposit within this space of disc. So this space of disc, which was having these delicate collagen fibers, is now going to have a dense extracellular matrix. That means this place is going to be really, really thick and will not allow the movement of solutes from this way or from this way. And there are loss of fenestration, the loss of microvilli, the Kupffer cells get activated. All these things are going to produce a number of fibroblastic growth factors and is going to cause fibrosis. Now coming to the vascular changes, there is loss of sinusoidal endothelial cell fenestrations. We have seen that there is development of portal vein, hepatic vein, and hepatic artery portal vein vascular shunts. There will be a portosystemic shunts which will be seen, and all these things are going to cause a defective liver function. So these shunts are going to shunt away the blood. That means from the portal vein towards the hepatic vein, or from hepatic artery towards the portal vein, there will be a shunting of the blood, and these things are going to cause defective liver function. They will be not able to exchange albumin, clotting factors, and lipoproteins. All these things are going to be important in seeing a lot of in seeing the clinical features, which we shall be discussing in a while. They will be aggravated by the loss of microvilli from the hepatocyte surface, right? So now you can spot the differences. You have this activated myofibroblast, you have dense extracellular matrix, you have lack of fenestrations, you have loss of microvilli, you have this activated macrophage. All these changes are going to be seen in liver fibrosis. Now that excessive amount of collagen, from where does it come? As I told you, from these perisinusoidal stellate cells or ito cells. So these things are coming because of damaged hepatocytes. It will cause formation of these reactive oxygen species, growth factors, cytokines, lymphotoxins, and these things are going to stimulate the Kupffer cells, and the sinusoidal endothelial cells will form transforming growth factor beta, will activate the stellate cells, will activate the growth factors, cytokines, and chemokines even further, and will lead to proliferation and synthesis of collagen. Plus there is some balance or imbalance between the activation of metalloproteinases and TIMPs. So here you go, you can see this is a normal liver lobule. You have the central vein, you have this portal triad. Only this area is having some fibrous tissue. This area is completely devoid of fibrous tissue. You have these hepatocytes which have been zoomed out over here. So any kind of noxious injury, alcohol, viral hepatitis, is going to cause the cell will undergo necrosis. The enzymes will leak, the cell debris is going to form, and this enzyme leak is further going to damage the matrix. It is going to produce more cytokines. All these things are going to cause a number of events like activation of the Kupffer cells, which are the hepatic macrophages, and chemotaxis of the inflammatory cells. More inflammatory cells will come there. These activated Kupffer cells are going to produce growth factors and cytokines. These growth factors and cytokines are going to activate these quiescent stellate cells, ito cells, fat cells, which are going to become a myofibroblast, which is going to produce a transforming growth factor beta, which is going to further cause more chemotaxis, and also is going to produce a extensive amount of extracellular matrix, which is more dense. You have more type of 1, 3, and 4 collagen. You have more amount of proteoglycans. You have more amount of matrix glycoproteins. All these things will lead to fibrosis, and this fibrosis is going to be a bridging type of fibrosis, which will lead to formation of these nodules, which is going to cause disruption of the architecture. And what is those three things? That those three things are called as cirrhosis, isn't it? Those three things are called as cirrhosis, which may have their own complications like cholestasis, portal hypertension, metabolic failure, which we shall be discussing a little later. Now, how does the liver look like? You will have a continued loss of hepatocytes and fibrosis. Of course, the cell necrosis will be seen, plus there will be extensive amount of fibrosis which will be seen. You will see a lot of fibrous septa. You will see hepatocytic regenerative nodules which can be micronodular. Chronic alcoholism, alcoholic type of hepatitis will have a micronodular cirrhosis more commonly. It's not a rule, but yeah, most of the cases of chronic alcoholism will have a micronodular type of cirrhosis, and most of the cases of viral hepatitis may have a macronodular type of cirrhosis. So along with that, hepatotoxins like CCL4, mushroom poisoning, a lot of pharmaceutical agents, acetaminophen, alpha-methyl-dopa, and even alcohol in some cases may lead to a macronodular type of cirrhosis. Now you can see over here, this is used to be a liver, right? This doesn't look like liver anymore. This looks like some kind of an ugly tissue which has lots of nodules on its surface. Some nodules are small, some nodules are large, so we can call it a macronodular type of cirrhosis. You can see over here, you again can see a lot of these nodules on the surface of the liver, which are quite diffuse, right? And if you cut this liver, it is going to be very fibrotic, very gritty. So this is again a macronodular type of cirrhosis. So you can see here, this is a very fine cirrhosis, so this is more likely to be a micronodular type of cirrhosis, right? Previous one was macronodular. Even this one is a macronodular type of cirrhosis, which is more commonly in viral infections, whereas micronodular is more common in alcohol-related fibrosis. You can see here, this is a nodule of hepatocytes over here. You cannot really make out any central vein. Forget about portal triads. You have this extensive amount of fibrosis which is running from one end towards the other end. You can see these nodules from small size to large size nodules, right? An extensive amount of fibrosis which is surrounding these areas. Again, you can see this extensive amount of cirrhosis. Now, if this is because of alcohol, you will see some amount of, we have seen the toxins, right? They can lead to the fatty liver. So along with cirrhosis, you can also see some fatty changes inside these hepatocytes. So this is a normal liver, a beautiful liver, and you can actually touch this and you can say, okay, yeah, this is quite smooth, the surface is very smooth. But if you touch this liver, now it doesn't look very beautiful. It's not so beautiful liver. So if you touch it, you can actually feel that this is having a lot of nodularity, which is called as a, in some cases they even call it a hobnail appearance. Hobnail appearance is a micronodular appearance commonly seen in Lennox cirrhosis or alcoholic cirrhosis. So here you have the normal liver, and over this side you have these small nodules which are surrounded by fibrosis. So this is the nodular disruptive architecture of the diffuse architecture of the liver. So here you have the central vein portal triad, you have fibrous tissue only in this area, and here you have central vein. I really cannot make out any central vein over here, but you can see this is a liver biopsy in which you can see extensive amount of nodularity which are surrounded or separated by extensive amount of bridging fibrous bands. This is a trichrome stain, a Misson trichrome stain, which is actually a special stain for collagen. So it won't stain hepatocytes that blue as it is going to stain the collagen. There's another slide in which you can see this collagen which is seen surrounding these hepatic nodules, and see so nicely, so beautifully it is surrounding these nodules everywhere. It is going to surround these nodules. Again, on another trichrome stain, you can see these bluish blue collagen fibers surrounding these pink hepatocytic nodules. Now, what will be the clinical features? There are going to be a lot of problems in these individuals. The first thing which may happen because of extensive amount of cirrhosis in these individuals is portal hypertension. Now, portal hypertension means that there is difficulty of the movement of blood from the liver, because this liver is going to be cirrhotic. This liver is having a lot of nodularity, so this is like a traffic jam inside the cirrhosis. So if you have a traffic jam, let's say in this particular area, what is going to happen? The people are going to follow alternative routes, right? So if you cannot pass through this, you're going to open the alternative routes. I should go from this side, or I should go from this side. So all these alternate roots will be open. So what is going to happen? You will have this periumbilical veins will open up. Those roots which were earlier closed, the periumbilical vein is a closed vein which is present near the umbilicus. Those things will be open and will lead to the periumbilical caput medusae, which is actually a Greek goddess which has this hair, looks like snake, right? So the same kind of image is seen, is called as a caput medusae. You may have all that portal circulation, all those things which are involved in portal circulation. You have these esophageal varices will be seen again, which is because of the portal hypertension. You will have splenomegaly, which is again because of portal hypertension, and this splenomegaly is further going to cause hypersplenism. And hypersplenism means you are going to have reduced number of RBCs, reduced number of platelets, and the patient is going to suffer from anemia and thrombocytopenia, right? Isn't it? Yeah. Plus it is also going to have these hemorrhoids, which are all open up, all dilated veins around the rectum, dilated veins around the esophagus, dilated veins around the umbilicus, and enlarged spleen, which is going to cause hypersplenism. These individuals are going to have something called as a Palmer erythema, spider angiomas. All these are because of increased vascularization. They are also going to have something called as testicular atrophy. Yeah, they're going to have testicular atrophy because liver is involved in synthesis, is involved in metabolism of estrogen, and it keeps a nice balance of androgens and estrogens. So in patients suffering from cirrhosis, the function of the liver is disturbed, and there is going to be increased amount of estrogen, which is going to lead to hyperestrogenemia. So these individuals may have gynecomastia. If it's a male, he will have a gynecomastia, will have testicular atrophy. There will be ascites, and this ascites is attributed towards either portal hypertension, plus there will be lack of formation of albumin, right? The serous liver is involved in synthesis of albumin, so there will be hypoalbuminemia. So these two things together, so if it's portal hypertension, you will have increased hydrostatic pressure, and if you have hypoalbuminemia, it is going to disrupt your oncotic pressure, which will lead to a net movement of the fluid outside the vessels and will lead to ascites. Plus hepatic lymph is also going to leak. Thoracic duct is not going to accommodate a lot of lymph. It will say, oh come on, so sorry. So you can use some other route, and will lead to formation of ascites, which is accumulation of fluid inside the peritoneal cavity. A lot of other problems will be occurring. There will be a lot of things will not be produced. There will be malnutrition. These individuals will have malnutrition because a lot of dietary amino acids, carbohydrates, lipids, etc., they will not be formed by the liver. Also, liver is involved in conversion of ammonia into urea. So if liver is having some problem like cirrhosis, this thing is not going to happen, and this ammonia is going all the way to the brain and will lead to hepatic encephalopathy. Liver is also not going to produce those coagulation factors which are produced in the liver. For example, 2, 7, 9 and 10. These are the factors which are produced by the liver. So if these factors are not being produced, the patients will also have coagulopathies, right? They will have coagulopathies. They will have esophageal varices which may bleed. They will have thrombocytopenia, due to which they may bleed. They will have coagulopathies, due to which they may bleed, right? So there are a few things which may lead to bleeding in these individuals. So these are how the clinical features are explained. So some of the patients may be clinically silent, may have anorexia, weight loss, weakness, and in advanced cases will have a frank debilitated state. If it's hepatic failure, it will be having it, which may be precipitated by systemic infections or a GI hemorrhage. The death is due to progressive liver failure when the liver has failed. The complications related to portal hypertension, which we have just talked about, and last but not the least, hepatocellular carcinoma. So these individuals are going to have portal hypertension. Why? Because the liver is completely jammed. It's not going to allow a lot of fluid movement inside it. So there will be portal hypertension where they will be causing esophageal varices. It will be causing caput medusae. It will be causing hypersplenism, hemorrhoids, ascites. Why? Because of hypoalbuminemia, because of increased hydrostatic pressure, because of lymph leakage will lead to ascites. It will lead to splenomegaly, again because of portal hypertension. There will be splenomegaly and will lead to hypersplenism. Hepatomegaly in some cases, but towards the end this is going to cause contraction of the liver. The size of the liver may be small because of the fibroblastic reaction, and remember there is a myofibroblastic proliferation. So this myo is going to cause contraction, and we know that the wounds contract, the scars, they contract and will lead to some contraction of the liver as well. These individuals are going to have jaundice. How can I forget that? These individuals are going to have jaundice because of cholestasis. The bile is going to get accumulated within the liver. And what type of jaundice would you expect? Is it going to be an unconjugated or a conjugated type of jaundice? Yes, this is going to be a conjugated type of jaundice because the liver is abnormal. So the type of jaundice is going to be conjugated. There will be estrogenic effects because of hypoestrogenemia. There will be coagulation defects. 2, 7, 9, 10 are the factors which are produced by the liver. So if liver is failed, encephalopathy because of increased amount of ammonia which is going to reach your brain and will have encephalopathy. The patients will have those flapping tremors, also called as asterisk 6 tremors, or also called as liver flap. These are the things which will be seen in these liver flap. Hepatic enzymes, what are going to happen to the hepatic enzymes? Hepatic enzymes, for example, transaminases, they are increased in those individuals which have hepatic damage. So if somebody is suffering from hepatitis or something, they will have increased amount of transaminases, right? If somebody is having any membrane or obstruction or bile stresses, they are going to have increased amount of alkaline phosphatase, gamma GTP, which is called as gamma glutamyl transpeptidase, and 5' nucleotidase. These are the enzymes which will be elevated in bile stresses and obstruction. So you can always remember this rule: transaminases are elevated during hepatocyte damage. Alkaline phosphatases, GGTP, 5' are going to be elevated during bile stresses or obstructive reasons, right? So we can see here the common enzymes which will be elevated: AST, ALT, LDH, because of hepatocytic integrity is lost. You may have serum bilirubin, which may be high because of there is defect in the biliary excretory function. You can see serum alkaline phosphatase, serum gamma GTP, 5' nucleotidase are also activated. They are also elevated because of damage to the bile canaliculi. Serum albumin levels will be less. Prothrombin time will be high because factor 5, 7 and 10 prothrombin, fibrinogen are not being produced. Serum ammonia is going to be elevated. These are the common tests which are done to test a lot of things like hepatocytic integrity, biliary excretory function and hepatocyte function. Jaundice, you can see yellow color eyes, and please remember that the jaundice is not a diagnosis. You cannot say this patient is suffering from jaundice. This patient has jaundice, fine, but this patient is not suffering from jaundice. Where else do you see? You see this jaundice mainly at this bulbar conjunctiva, right? And where else you can see on the palms, this is the normal hand, how it looks like, and this is a jaundice, the palm of a jaundice patient. You can see, you can actually compare a lot of difference in the color. It's quite yellow over here. So all cases of hemolytic, so this jaundice is going to be conjugated type because it's an obstructive problem which is happening. So if it's an obstructive problem, you are expecting alkaline phosphatase to be high, we're expecting GGTP to be high, you're expecting 5' nucleotidase to be high, and you're expecting a conjugated type of jaundice in patients suffering from cirrhosis. If it's hemolytic anemias, you will have unconjugated type of jaundice because this thing is going to happen much before the conjugation is occurring in the liver. Now, one of the complications which we have discussed, portal hypertension, we will go slightly in detail. So the venous blood from the stomach, intestine, spleen, pancreas, gallbladder, which passes through the portal vein in the liver. In sinusoid, it gets mixed with oxygen-rich blood of hepatic artery. It comes in contact with the hepatocytes. So liver blood flow is around 15% of the cardiac output, which is quite high. And portal vein pressure is only around 4 to 8 millimeter of mercury. So whenever there is a vascular bed restriction, it is going to cause compression of the central vein, which is mainly because of the extensive amount of fibrosis which occurs in these individuals, and these expanded parenchymal nodules are going to cause increase in the portal vein pressure, which is finally called as portal hypertension. 4 major clinical consequences we have talked about that. Ascites will be seen, there will be portosystemic venous shunts, there will be congestive splenomegaly, and this is going to cause hepatic encephalopathy. We have discussed all these opening of various vessels, hypersplenism, formation of excessive amount of ammonia. All these things are the major clinical consequences of portal hypertension. There will be collection of excess fluid, more than 500 milliliter in sinusoidal, post-sinusoidal, and post-hepatic obstruction. So you have drainage of protein-rich hepatic lymph, which is impaired. You have increased portal pressure, you have hypoalbuminemia. All these things are going to contribute towards ascites. It's not only just one thing, a number of things are going to contribute towards ascites. So these portosystemic venous shunts are going to open, they are going to cause opening of various vascular channels that bypass the liver. The veins around and within the rectum are going to be dilated. It's called as hemorrhages or piles, right? You can call them piles as well, or some books even call them figs. Cardioesophageal junction, you have esophageal varices. These are snake-like dilated veins. If you do an endoscopy, you can see these snake-like dilated veins which may rupture at any time and which can be life-threatening to the patient. There will be retroperitoneal and falciparum ligament of the liver, and which will open up these periumbilical abdominal wall collaterals, which is called as the caput medusae. Wow, this is how ascites looks like. So you can see this eversion of the umbilicus. You can see there's a lot of fluid. You can see the veins are dilated. So why this happens? Because there's accumulation of fluid. This is ascites. It's definitely more than 500 milliliter. And you can do a few tests like fluid thrill. You can just tap at one end and you can feel the wave which goes towards the other end. So it's not air, it's not a mass, it's actually the fluid which is present inside the abdominal cavity. So it's called as a fluid thrill. You can see these dilated veins. These are called as spider angiomas, also called as spider nevi. There's a small dilated arteriole. There's small dilated arteriole in the middle, and you have these small arterioles which are surrounding it, and it looks like a spider, and that's why we call it a spider angioma or a spider nevi. Congestive splenomegaly is going to cause hypersplenism, anemia, and thrombocytopenia. Hepatic encephalopathy is going to cause increased amount of ammonia which reaches the brain, will cause encephalopathy. The patients will have hysterexis tremor, flapping tremor, which is a non-rhythmic rapid extension flexion movement of the head and extremities, which are best seen when the arms are held in extension, and dorsiflexed wrists. So various things. Any kind of obstruction, all obstruction will lead to portal hypertension, which can be because of these problems will cause esophageal varices, will lead to hemorrhoids, will lead to parambilical veins. So if you have something which is happening here, the jam is actually happening over here, so it is going to cause this shunting of the blood and will lead to esophageal varices, will cause opening of the parambilical veins, will lead to caput medusa, and will lead to opening up of the rectal venous plexus and will lead to hemorrhoids. So you have these consequences: esophageal varices, caput medusa, and hemorrhoids. So this portal collateral circulation may also lead to encephalopathy. There will be malabsorption, there will be ascites, there will be hypoalbuminemia, decreased thrombocytes, decreased clotting factors, rupture of the varices. All these things may lead to bleeding, which we have discussed earlier. So all these features we have discussed, and we actually now know what are the causes, what is the real story behind all these clinical features which are happening in these individuals. So with this, we are going to end our discussion, and next topic will be hepatic neoplasms, which will be discussed later. Thank you so much for your patience.